Good afternoon, everyone. Thank you for being here and sharing this time with us. In the next few minutes, I'm going to be talking to you about palliative care and hospice for persons with dementia. This is going to be actually a very, very practical presentation, and I've gotten some feedback about what people really want or need to hear about. And I've also sprinkled in a couple of stories, really sacred stories, that I want to share with you today. So I'm hoping that you do find this information helpful and that it helps you make which often can be very difficult decisions for these patients. So our learning objectives for today are to list the most important difference between hospice and palliative care. Continues to be confusion in many communities. And list the eligibility criteria for the diagnosis of dementia, if that were to be the primary hospice diagnosis. And then to discuss common occurrences in the trajectory of dementia that really require the most preparatory guidance. And I want to pause for a minute and have you think about, why is hospice care so important? You know, hospice care is the only organized form of end-of-life care that we really have in our country and certainly in our community. And Dame Cicely Saunders tells us that how people die remains in the memory of those who live on. And if you just think for a moment about a personal experience that you've had, I suspect you'll be readily able to relate to that. And it really is important. As we see trends in hospice care, late referrals have always been an issue. And in the last few months, not only in our hospice, but in hospices across our state, we're actually seeing later and later referrals to where up to 2/3 of patients are dying in the first week of their hospice care. And that is not hospice care. It just is not hospice care. And, you know, hospice is all about mind, body, spirit, and attending to a lot of needs that maybe have gone unattended to during the course of trying to treat an illness or multiple complications. So I want you to just keep this in mind today, now and really into the future. How people die remains in the memory of those who live on. And for those who live on, it can, if it's been a traumatic death, a death in the ICU or a death in the hospital, it can cause a post-traumatic stress disorder and impact personal health, healthcare costs, and just the ripple effect is incredible across the entire community. So how people die remains in the memory of those who live on. Also, in the context of quality, this is a quote from an article, a quality article that was published in 2018 by Saunders and Curtis, Randy Curtis, and Tulski in the Journal of Palliative Medicine. And they say, when we fail to provide care that matches patient preferences, we commit a medical error, no less urgent than any other harmful error. You know, we've been working at advanced care planning for 20 years now and still have a long ways to go. And we used to say, oh, he really wanted to die at home. It's unfortunate he died in the hospital. If we now think of that as a medical error, that's an entirely different context. And I believe this: when we fail to provide care that matches patient preferences, we commit a medical error, no less urgent than any other harmful error. So I ask you to give that some thought also. So what is palliative care? Well, palliative care really is a specialized medical care for persons with serious illness, always focused on the quality of life, whether that's relief from pain and symptoms or more complicated advanced care planning. But the goal is always to improve quality of life for both the patient and the family. And it's done by an interdisciplinary team that actually supports the primary care team in their care of the patient. And this is the CAPC definition that was first developed way back in 2012 and has had a minor modification since then. But it can be kind of complicated to remember, and I love the headline definition, a headline being 15 words or less. You know, what is palliative care? It's the best care possible from the patient perspective for a person with serious illness. So the best care possible from the patient perspective, which is such an important part of that for a person with serious illness. So let's kind of look at the entire realm of palliative care. And it really is three overlapping spheres. And the first of that is hospice care. And of course, that's the care that's given in the last 6 months or hopefully months of life. And it really is the smallest part of all of the palliative care that's done. Surrounding that is specialty palliative care done by persons who are specially trained or maybe board certified or certified in some program in specialty care. But the outer sphere is entitled generalist palliative care. And the majority of palliative care that is done today in our country is done by you folks. It's done by generalists, not by specialists. There's never going to be enough of us to meet the needs of the seriously ill population that we're dealing with today. And the other thing that's important to remember about palliative care is that most people that need palliative care are not dying. They are not dying. And palliative care got associated with hospice when it got linked. And I know in our organization years ago, when we first started palliative care, we were so happy to become, Franciscan hospice and palliative care. And we've been sorry ever since, because it's a barrier to palliative care, because people say, oh, my patient's not dying. He or she doesn't need palliative care. It's not about dying. It's about meeting unmet needs in a person with serious illness. So please remember that most of the palliative care that's done today is done by generalists, and most people who need palliative care are not dying. So does every person with dementia need palliative care? Well, it depends. It depends on the skill and comfort level, on the complexity of the situation. They need some aspects of palliative care. And I almost hesitate to say that, because I think so much of what is in the realm of what we consider generalist palliative care should be just good standard medical care. It doesn't, it shouldn't be a specialty. I remember when I was starting palliative medicine services and somebody asked me what palliative care was. I didn't have the CAPC definition, but I gave a description, and this was a gastroenterologist, and he looked at me and he said, well, isn't that just good medicine? And I said, it is, but it somehow got lost in all the technology, and we've had to recreate it, and we've recreated a specialty. So does every person with dementia need palliative care? Not necessarily, not necessarily. So what about hospice care? Hospice care is specialized care for persons in the last 6 months of life. And it was started honestly as an insurance benefit. It had nothing to do with the magic time frame of 6 months. And it's given by a specialized team and mostly done in homes or wherever the person is living, wherever they call home. And when we think of actually both hospice and palliative care in a person with serious illness, whether it's dementia or what it is, we like to think of no surprises, no regrets. And so the no surprises has to do with good advanced care planning, and no regrets, not hearing, which we continue to hear every day, I wish I'd known about this sooner. I wish I'd known about this sooner. Wish I would have been referred sooner. So in the areas of focus for a person with dementia in advanced care planning, appointing that DPOA, and probably that's the most important thing, as Barack has so elegantly told us, at the time of diagnosis of dementia or other serious illness, there needs to be discussion about caregiving and about nutrition and hydration and what is expected as the disease goes on. I was completing a death certificate yesterday for a woman on our service who just recently died of probably an Alzheimer's dementia. She was in the hospital a month ago with GI bleeding and kind of failure to thrive, and had some weight loss, and she was put on TPN. And it's like, what was that going to help? And so what the expectation is for the clinical course and counseling regarding nutrition and hydration are really a critical aspect of advanced care planning. Also treating infections. And then when is the right time for hospice? How can we predict, the 6 month time frame? And I'm not saying it's easy. I'm not saying it's easy. So when we look at the entire spectrum of a person who's been diagnosed with a serious illness, and we look at this model, which is the model we should all ascribe to in caring for these patients, whether it's dementia or other serious illnesses, is that palliative care in some form be introduced at the time of diagnosis and be given concurrently with a disease-modifying treatment or treatment that is even attempting to cure. It should be and can be given concurrently up to the point where those treatment options are no longer available and all of the care is exclusively palliative. And then the patient is deemed to be in the terminal phase of their illness and referred to hospice care. And then, of course, the bereavement care that is so important. When we think about doing all of this and caring for persons, we know that communication is the most important clinical skill we have. And many of you have heard me talk about the house model. And I just want to refresh your memory a little bit today. And this is a great model of communication for doing advanced care planning or having any conversation under multiple circumstances, always starting with relationship, then the patient's story, always getting the patient's story first before we launch into where we're really comfortable in the medical story, and then making that balanced recommendation and then collaborative decision making. I'd like to tell you a story, kind of about the patient's story wall here. And often we meet persons with dementia, we certainly do in our specialty, who are very advanced. And we're not talking with them, but we're talking with their family. And the clinicians are often inclined to talk about them in past tense. And I want to share a story with you that really has a powerful message to it. And it's not about a patient with dementia, it's about a patient who was actually dying in our hospice unit. And this was a number of years ago, and the patient's name was Jasmine. And Jasmine was a 20-year-old college student who was from Samoa and had a full ride volleyball scholarship to a university in the Midwest, developed a gynecologic malignancy that unfortunately did not respond to treatment. And she came back to this community where she had a large family and communities to support her. She had complicated pain management needs and was actually in our unit for a couple of months before she died, and we got to know her very, very well. And as she got closer to dying and really transitioned into the active dying phase, she became unresponsive, was even unresponsive during care, had not taken anything to eat or drink for a number of days, hadn't even opened her eyes. And two of our staff went in to care for her, and one of the staff was orienting, and the one staff member said, "Jasmine was a volleyball player. Anybody want to predict what might have happened?" No takers. Jasmine opened her eyes and said, "I am a volleyball player." So what a lesson from Jasmine. So we have to remember, whether a person is unresponsive and dying from whatever, that they are while they're living. And I love to tell that story of Jasmine, and to think about how they die remains in the memories of those who live on. Her family came back to visit us every year on the anniversary of her death. I did not know that until the 10th anniversary, and the mother asked to speak to me. And as I was walking down the hall, I realized who it was, and I just had no concept it had been 10 years. But indeed, the mom told me that they had come back every year on the date of her anniversary of her death. But they didn't have the energy to talk to anybody. They just came into the building and had the experience. But on the 10th anniversary, they decided to talk to staff. And the mother asked if I was still here. And it was such a privilege to talk to them and to recount some of the memories they have. And those memories really do live on. So when is someone with dementia eligible for hospice, eligible for that insurance benefit, that incredible interdisciplinary team? Well, there are certain eligibility criteria. And these criteria have been established by CMS. It's actually the different intermediaries across the country that have set the criteria. And these are the ones that are currently for our area with National Government Services. So the patient must, on a FAST level or FAST equivalent, be a 7 or higher, which is the inability to ambulate without assistance, inability to dress without assistance, incontinence, and no meaningful verbal communication, and have had one of the following in the last 12 months. So a complication, an infectious complication, decubitus ulcers, fever, or weight loss, a 10% weight loss. So for a patient with dementia to be on hospice, those are the criteria, if indeed hospice is the primary diagnosis. Now, most patients today have 5 or 6 diagnoses, and it's our responsibility to determine what is the primary hospice diagnosis and what are they most likely going to die from. Then to stay on hospice, they have to continue to decline. And this is where the hospice benefit today really fails dementia patients, because the hospice benefit was established for cancer patients who have an often very predictable steady decline. And that's not how our hospice patients die. We all know that. So it can often be very difficult, particularly if they've had symptoms that have been out of control, like pain, and the pain is now well managed, and they start eating and start being cooperative with care. So the ongoing decline, if there is not evidence of ongoing decline, then actually we are required to discharge them until they do show evidence of decline and they can come back on. And we do that all the time. And we've always referred to those patients as graduating from hospice, and it's not graduation, it's being kicked out. It's being kicked out. That really is a much better term. Families are devastated, families are harmed when we take those services away. So we really need to continue to advocate for a different benefit for our patients with dementia. So when should you refer person with dementia to hospice, or any patient that you think is approaching end of life? Well, I ask you to think when you would not be surprised if this person dies in the next 6 months. All of the eligibility requirements can become very confusing. I can't remember them all. I look something up probably every single day. But the surprise question is a great screening question. So if you would not be surprised if the patient you're taking care of dies in the next 6 months, please talk about and refer that patient to hospice. It is then the responsibility of the hospice to certify them as having a terminal illness and bringing them on. And if they don't qualify, and I just got off the phone an hour ago with a patient that had been referred for dementia and really did not qualify. But now the wife knows more about hospice and knows when to call us. So that's okay. So think about the surprise question as a great screening question for making that referral to hospice. So what are some hospice myths that we continue to hear all the time? Well, first one that's really quite common is a hospice patient can no longer see their own doctor. Absolutely not true. They can continue to see you, particularly if you are designated as the attending of record, and they could even see a specialist. The problem with that is that the billing has to go through the hospice. And many specialists say, I'm not going to see another hospice patient because the last time my bill got denied. Well, that's because the office didn't understand the billing, and the billing has to go through the hospice, and then the hospice gets reimbursed by Medicare. So a hospice patient can continue to see their own doctor, and they can continue to see specialists if indeed that fits in the plan of care. After hospice care is started, people die. How many of you have heard that? My brother said that to me one time. My neighbor, he said, Mimi, they called in hospice and then he died. I said, Bill, your neighbor was dying and they called in hospice. That's the way it goes. But often people associate calling in hospice with dying. It's just the opposite. Many people think that all of caregiving and all of care is paid for in hospice. Medicare, which is the primary payer for hospice, does not pay for any custodial care, and that can be a real barrier. Particularly people out of the hospital may choose their skilled benefit because that is paid for a certain time. And if the patient has to go to a nursing home and be on hospice, the room and board aspect then has to be paid for by out of personal expense. A person can only be on hospice for 6 months. They can be on hospice for as long as they meet criteria and continue to decline, and it's documented. Most medications are stopped when hospice care is started. Absolutely not. The majority of medications that are given today for the most common serious illnesses are all palliative medications, whether it's digoxin or Lasix. So most medications are not stopped, and it can actually trigger a symptom crisis if medications are stopped. And persons with dementia don't really experience pain. Absolutely not. And these people, pain is a significant factor towards the end stages of dementia. So I wanted to just talk for a minute about pain assessment and using the pain AD scale. And this is a 5-item assessment where the patient is unable to report the level of pain, and breathing and negative vocalization, facial expression, body language, and consolability are all rated. And it's a 0 to 10 scale, similar to the 0 to 10 pain scale. And this is the resource for that talks about really how to use that scale on assessing a pain or assessing pain in a person with dementia. So I want to end by sharing Margaret's story with you. And I want to thank Barack for triggering my memory a couple weeks ago. And he made a comment about, the mind is just so complex. And I forget exactly what you said, Barack, but it made me think about Margaret. And Margaret was a patient on our service. This was many years ago, was in a facility and dying of dementia. And our chaplain was talking to her son and asking him what he was hoping for his mom, in her last days. And the son said he really wanted her to receive the sacrament of Holy Eucharist. Born and raised a Catholic, practiced Catholicism all her life, and it was a very important sacrament to her. So Ray said, I will do that. I will take communion to her. So Ray did. He went in, he gathered his little kit, and he went into the room, and the staff had gotten Margaret up in a wheelchair, and she was kind of sitting slumped over in her wheelchair, but she was dressed nice. And Ray set up his little altar, and he went through the ritual and the service. Margaret didn't respond at all during the entire time. And as he finished up, he said, Margaret, I'm not sure how much of this, you took in, but I really gave this the old college try. Margaret lifted up, opened up her eyes, and said, and with your spirit. And Ray was thrilled to be able to tell that story to her son, that she really had known that she was receiving the sacrament of Holy Communion in her final days, even though it didn't appear such. And, that memory is going to live on in the memory of that son forever. So with that, I thank you for listening to me, and I am happy to take any questions if we have any time.
We have plenty of time, and maybe thank you so much for that wonderful overview, as well as just the personalizing of this really wonderfully important and critically important phase of care and of life, and then the resource also for assessing pain, which is incredibly difficult to do. So thank you for that. Yeah, questions, comments?
I don't have a question. I have a comment. This is Franja. You in your talk, you said something along the lines of, dementia is not really built well for hospice benefits, and so we need to build a dementia benefit. So we should just get right on that.
That's
That's my thought.
There are significant efforts being done to do that front. I think Linda's aware of that, and Jamie Teutenberg, who is a health policy fellow, is talking to the folks, and CMS is looking at that. The reality is we know how slow change is.
Mm.
Yeah. Brock?
Thank you so much, Mimi. That was amazing. And just to sort of follow on that last question about, just like, Mimi, what would you say, like, if you could like think of like the ideal dyad to like go out to the house of somebody living with dementia, like what would it be, like a nurse and a social worker, like a physical therapist, like what are, like, if you had to sort of name the like like a standard 2-person dementia benefit team, like who would you put on that team?
Brock, I would say it depends on the person and what their needs are and what's important to them. To some people, that would be a chaplain or some spiritual advisor of some sort. I think a nurse is key, a social worker is critical. In my opinion, every member of the team is so important. A dyad, at least a dyad would be great. The need is much greater than that. Much greater than that. Isabella, you had your hand up?
Yes, thank you. I'm wondering if you have any recommendations where I can find resources to share with my team on nutrition and hydration.
I can get those to you because, it's been in the literature for like 20 years about tube feedings and how unhelpful they are. And as I said, we still see that. We're still seeing people being put on TPN. Unbelievable. It's just heartbreaking when I saw that last week. It's like, oh my gosh, what were people thinking, And I can get you some specific resources. There are lots of good resources out there. Okay.
Mimi, I suspect that's something that many of our community would be interested in. So if you want to send those to either Allison or me, we can include those in the distribution of materials along with that pain scale. So
Okay.
Happy to do that.
And we have a member of the audience who does that module in the academy all the time on nutrition, hydration. If anybody ever would want to hear that, it's a great presentation. And Isabella, maybe that's something that we could offer your folks, but it's a whole model in our communication academy about artificial nutrition, hydration in the setting of advanced dementia and having that conversation using the house model.
Yes, thank you.
It's very powerful. So
Chris
thank
Frederickson.
you.
Oh, we have one more question from Chris
Okay.
Frederickson there.
Hi. I was wondering, are there adjunct services that are actually covered by Medicare, like massage therapy, music therapy, anything like that that are covered? I know that some hospice provides it, but are they actually covered?
That is not a requirement for a hospice program. It's something that in our particular hospice program we've been proud of. Unfortunately, COVID has really impacted our ability to provide those comfort services. And I think I can only speak really to that, Chris, in the setting of the hospice benefit. It's not a requirement for a hospice to have those services available, so it depends on if the hospice does have that resource. But
if they do, they are covered by Medicare?
Absolutely.
Oh,
absolutely. Mm-hmm.
I could share my screen for just a second just to show you guys. Like, so this is a really great sort of one pager that the Center for Advancement of Palliative Care has. That it's like a little cartoon that really has just a lovely sort of approach to what the conversation looks like. And I'll email that to Chris and Allison.
Great, thank you. All right. Well, again, thank you, Mimi, for such a wonderful presentation and just
You're
the
welcome.
work that you do. All right, so I'm going to transition here to our case presentation, and hopefully you can see that okay. And thank you again to Deborah Tillman, RNP at the Manette Clinic, a repeat case presenter and always much appreciated. Allison has done a wonderful job of importing your case into the slides, so I'm happy to drive those as you talk about this person.
Yes, thank you. I wanted to preface by saying not all of the folks on my patient panel are this type of presentation. So I try and save just those that are most vexing and challenging, and have some type of an overall question that I'd like to at least discuss. So this patient is a 74-year-old female. She's been in a secure memory facility for 10 months now. She was placed there last summer after a several month inpatient stay at the local hospital. She had about a 6, well, overall, she was relatively stable. There were some adjustments to be made once she got to the facility, but overall, she's been fairly stable until just the last couple of months, where there's been reports of persistent, intermittent, destructive agitation, lashing out at staff, etc. The family goal is comfort. They would prefer not to go to the emergency department again because she's had such poor courses at the emergency department, especially 3 in sequence last month. And in that last month, her complications are that she was diagnosed with a UTI, but she's been resistant to taking the medications. The nursing supervisor for the facility has gone. There is staff present, aides and med techs who are trying their best, but have little in the way of skill, especially to do things like redirect or time to assist this patient, who does pretty good if you can just redirect. But this has allowed the patient not to be sent out to the emergency department. It's kind of an odd situation where, because there's no nursing supervisor, there's nobody really to say this patient shouldn't be here anymore. We need to send her out. And over the last month, on the heels of the UTI, another COVID wave came through this facility, as many other on the Kitsap Peninsula. She was one of the few that actually was symptomatic. And the family, instead of saying, no, let's just do comfort, they said, we want everything. So she did get medications for the symptoms. And the family has been unable to come visit her because they also have tested positive. And the patient has not taken all of her medication for symptom control either. So it's really a complicated situation. But one of the things I wanted to talk about is how to support staff when there is a lack of administrative support to redirect. How do they deal with medication administration struggles? All these folks are wanting to do the right thing, but are pretty overwhelmed in the situation. So if we can just go forward. So here are her diagnosis list is actually relatively small. She was diagnosed with dementia just last summer as a part of her extended hospital stay. And in addition, then she had the acute metabolic on chronic encephalopathy. And it was definitely linked to a UTI that had been unrecognized in her home with her spouse. She also has some chronic pain issues, pretty severe kyphosis. Again, not well controlled when she was in her home. If we can go ahead and go forward. Retired realtor. She smoked heavily the vast majority of her life. Only was taken off, only quit because she was an inpatient, and then we weaned her off with nicotine patches. No alcohol or illicit, but a lot of caffeine, and she used to walk. So other than that background information, I didn't know much about her history, in part because she never sought out medical care. And only in the last 2 months, the daughter, who had lived out of state, has now moved to be helpful. The daughter has some medical background, and so has kind of taken over from the spouse's care or oversight, and says that her mother has always been moving about, always fussing, sleeps random times. And these are including on the couch when others are around her. These are all things that the staff at the facility had worried about. But the most important key that I was unaware of is that her whole life, she had had undiagnosed mental health concerns. And refused to seek care for them other than a stay at some point in a mental hospital. She had sustained significant abuse. The daughter didn't go into what that was, didn't really seem pertinent at the point, but had never, her mother had never sought out care, but self-treated with cigarettes, with caffeine, with staying very busy. And the daughter had mentioned a couple of meds that might be helpful. So it tells me that there's a family history of other mental health struggles. She knows that the family in general knows she's not hospice qualified, but has wondered about palliative care. There was a referral that happened while inpatient last month. I tried to contact several times to make that actually occur, and it never did. So I'm not sure what happened there. But the daughter also felt that pain was being very poorly controlled. Now, this is someone who hadn't been with us caring for her mother since August of last year. So the daughter is coming in with new information, but also unaware of really what efforts have been tried to date. So also a history of some high blood pressure and osteopenia. There's a couple of other meds that we just stopped in an effort to decrease the pill burden. These are the meds that she's on. And actually, since I wrote this, I've adjusted again. She really didn't have any of these when she started at the facility. The family didn't want much for medications. What has happened over the last couple of months, well, since probably December, is she's been spitting things out, refusing to take meds, spitting them out. It worked for a while to hide the medications or crush them in food. And just this last week, I changed everything over to liquid, which she also is refusing some of the time. Okay, so go ahead. And then what I have on this series of slides is just, this was the original admit last summer. The daughter said that she actually had a cognitive decline for 2 years prior to that, but nobody said anything. They just tried to go along with her change of behavior. But then there was essentially a week of much worse, where 911 had to be called, and they had to chemically restrain her in order to get her to the hospital. And the reason I include some of these hospital evals is that this is the first diagnostic information, imaging, etc. There's the CT that shows no acute issues, but chronic small vessel ischemic disease, and then the acute on chronic. And because of this, then she ultimately was transferred to secure memory. Go to the next slide. The stability for several months, and then just last month, an abrupt change. Well, I wouldn't say abrupt, but worsening fairly quickly. She was sent out to the emergency department for fatigue, and you can see some of her most recent labs there. They did a drug screen just to make sure that there wasn't something remarkable going on there. And they said that this was just a medication side effect, that she was taking too many medications, including the Haldol, which they'd actually prescribed. Maybe these slides are not quite right, because the hospital had prescribed the Haldol. I hadn't. They had done it in inpatient. So we'll go to the next. All right. And then there's the very next day, she was sent back to the ED. This time she was 100% cooperative, wasn't in the hospital for very long because she was fine. So she can be redirected. She had one brief episode where they gave her yet another benzo IV, and then said she's just got dementia with aggressive behavior. Okay, and then the next slide. Oh, yeah. All right. I think we just missed one slide there. There were 3 emergency room visits where, yeah, it doesn't really matter. There were 3 emergency room visits last month where the medications got changed by the emergency room staff, which is part of the reason why the family doesn't want her to go back again. I have talked to the daughter several times this week, including this morning, where the family is now to the point where they would prefer that she go out to the hospital. They don't want her to remain in this facility. They don't feel like it's supportive of her. She needs higher level of care. Yeah. Okay.
All right, Deborah, thank you for the overview. I'm curious,
Yeah.
questions from our community here, things you'd want to know before we think about recommendations, other information?
Hey, Deborah, this is Franja.
Yeah.
I'm curious, what's her functional status like right now after kind of all these things that have happened?
Well, I just saw her in person a couple of weeks ago. She was busy walking about the relatively large common living area, but was easy to redirect, sit down, have a meal. She ate finger foods, was able to swallow. She had some appropriate 2 to 3 word responses to me. So she can be cooperative. But there are episodes that seem to start without any external stimuli. It's some type of internal stimuli. According to family and staff, say that it's just like a light switch, and all of a sudden she becomes very aggressive, and she will start going around pushing chairs over and sometimes tearing apart her room. The worst was that she took the porcelain cover off of the toilet tank and threw it on the ground, shattering it. And she's gone into somebody else's room and torn apart some of their items. So it can be from, that one extreme of being very aggressive with physical things to being 100% cooperative if you redirect her. And she recognizes her family still. She knew that her daughter was coming to, had her daughter's name right away, and knew that the daughter was going to be coming at the beginning of last month to help care. So there's quite a bit that's pretty high functional.
Denise.
Hi. Let me get this out there. Hi. I'm curious about 2 things. Her pain management now, is that adequate? And I may have just missed this a second ago. I had to take a quick phone call, but her pain management was one thing I was concerned about. And then the other is the facility itself. You may be aware of the long-term care ombudsman program. And if not, it's a great program to help. Their goal is to represent residents' rights. And so if things are not hanging together well at that facility, the ombudsman can be called in to negotiate, to navigate between the family, with the staff to get adequate care going on. Sounds like that's pretty significant. But anyway, those were my two thoughts on this situation.
Yeah, the pain control has been a little bit of a puzzle. Started out with just a little bit of ibuprofen and a little bit of Tylenol, and that seemed to work okay. But as the months have gone on, not so much. She has a listed allergy of hives and nausea and vomiting to narcotics. And the family would prefer that she continue to walk as much as possible. So I have increased the ibuprofen just a little bit. Her Tylenol is at the max dose. Staff had suggested things like Tiger Balm because it seems to be mostly related along the spinal column. There's pain there. So I've added gabapentin, and that seemed to actually help quite a bit. Yeah. As far as an ombudsman, yes, it would be a great idea. This facility in particular, it was doing really well and then not so much. And they've struggled to keep a nursing supervisor, and that seems to be the link of the staff being despondent and feeling like they're not adequately supported either.
Sure.
Yeah.
And one other question, what about the donepezil? Do you think she's benefiting from that?
She did, I think, at first. That was one of the first medications along with the sertraline that I added. That was this last fall, and she seemed to do pretty well with it. Felt like that was her most stable period.
Oh.
Yeah.
In
fact, yeah, with the sertraline, she actually did really well. We thought that was probably the biggest change for her.
Great.
Yeah.
Patricia, I think you were the next with the hand up there.
All right, thank you. Great presentation, Deborah. And I wonder, number one, has she been declared incompetent? I know that she's functionally incompetent, but I'm wondering, again, how the family is able to make all of this. I presume she didn't have a previous advanced care plan to address this kind of situation. And then secondly, do these outbursts happen? Are they considered a sundowning event?
Yeah, great question. She does have a durable power of attorney with her spouse, who is actually fairly competent, lives independent. He just has real hard of hearing issues. So he is present and a part of it, but the daughter is essentially the contact that I've had for most of the last couple of months. They have a post that says limited interventions. They do want things like IV antibiotics, IV fluids. The original statement had been, we want just comfort, but they have since signed a post and said, no, we want some interventions. And then there are reports of sundowning, that she seems to be more agitated into the evening. And we've tried to address that. The daughter goes in the evening, early evening, to try and be there for those episodes. And really things went sideways when the COVID wave came through and the family wasn't able to be there both in the morning. Husband goes mid-morning and then the daughter goes late afternoon. So yeah, there's probably some sundowning in there. Yeah.
Good. And Julie.
It's definitely a nerve-wracking situation. I feel so for the family and the patient. I think that the pain seems to be the thing that might be most palliative in nature, and maybe something to address further. And you're saying back pain and the gabapentin was effective. Maybe there are there's more avenues to pursue with the pain management in terms of referrals and better pain management there. And then I was wondering about sleep and how you said sundowning. So how is sleep doing? And maybe there's further room for improvement and modification of medications for sleep too.
Yeah. I haven't heard reports much of insomnia. That was originally reported, but the staff don't tell me that she's a poor sleeper or up overnight. She does have a trazodone. I think it's 50 in the evening, and that seems to work well for her overall. This struggle pretty much the entire time is that she refuses medications. So I keep adding, and this is for me as a provider, how do I overcome this? I've got this list of medications, and yet there's no way to get them inconsistently. The struggles with the antibiotics recently and the antiviral are that she only got about, I don't know, 2/3 of the total course, which those are at least acute illnesses. These chronic conditions, she's just not taking the medications consistently. How do I get that to occur? And we just changed over to the liquids. I don't know if she's spitting those out too. So I think that the pain control would probably assist with some of this. And the family is very interested, again, in palliative outreach to try and determine if maybe it's pain that can be controlled through palliative care. But again, how do we get her to take it?
Yeah, I mean, when it comes to mind with the pain is that if she's uncomfortable, Butrans at a low dose I'm not to prescribe for but I think there are transdermal ways to treat pain that could be done low dose and kind of monitored. Yeah.
Very good question. When you mentioned that she's responding to some internal experience, obviously pain is one thing and trauma is another. So what might be upsetting her or driving some of those behaviors.
Yeah.
I see, Jeff, you have a hand up also.
Yeah, so Deborah, I'd like to come back to one of your first points because it's what I think I'm seeing most in Yakima, and that is that these nursing facilities have just gotten beaten up. Huge amount of turnover. The experienced people had enough and left, and then we're taking people who are much less adept in their skills and their patience and knowing how to work with these folks. And training in the 80s, the talk was try not to prescribe because the issue is the redirection. And what we're coming back to is being told to prescribe. And my personal feeling is I have not been trying not to do more prescribing, but I'm also seeing more complaints of this type. And unlike you, we don't have a secure place we can send people to. And so then families are angry because they're afraid they're going to be sent back home and they're not equipped to deal with them. And so we're being, at least as a primary care provider, put in a terrible position of solve this, and I can't solve it. At least I haven't been successful at solving it. And I haven't found that I think the multiple talks we've had from speakers, the medications at best have modest benefit, which is not clinically significant benefit, but statistically significant. And so what I'm looking at is how do we help these facilities to help these patients when the facility, just as in all of healthcare, people are saying, I've had enough. And yet they're held to these standards of you're not doing a good enough job when they can't. So I realize I'm rambling on, but I think we have to look at a bigger picture because I don't think we're going to solve these problems with additional medications. I think we just, in my experience, we create new problems. So I get the calls to put them on something for pain or put them on more antipsychotic or put them on a benzo, knowing that the likelihood of benefit is small and the risk of falls and then dealing with that consequence is high. So yeah, I'd really like some input about how do we work when the system is collapsing around us, which at least in Yakima is how it feels in some ways. How do we support these places so that because we're having to provide support to these institutions. Thanks for letting me drone on.
No, I really appreciate that comment. Yeah, I hate adding something like an alprazolam, but it is literally the only medication that she will take. I don't know whether it's causing poor side effects or, kind of a boomerang, but it is the only med she takes. And the staff say that it helps at least for a couple of hours. So I continue on with it. And I want to support the staff. I can't imagine having a resident who is throwing toilet lid tops down on the ground and shattering them. That has to be very overwhelming for staff.
There's an interesting conversation or some comments in the chat if you're not tracking them. Jeff, to your point too, and Deborah, that in many of our communities there aren't other options. It's not like there's another skill or a locked facility or adult family home. It may be that this is the place. So I'm curious too. There are also some questions regarding either Isabella or Janine, if you want to unmute and maybe ask that or make that comment.
Hey there, this is Janine.
Oh, hi, Janine. Go ahead.
Okay, this is Janine. I'm a geriatric nurse practitioner. I was curious if the setting might benefit her if she went to an adult family home that has experience with dementia and behavior interventions, just because she's been to the ED so much and they don't want her to go. And I feel like sometimes if people are experiencing, they're not burnout, hopefully, they could perhaps be a better setting for her if they're experienced with dementia.
Yeah, absolutely. That is where the daughter and I were going this morning during our half an hour discussion, is that the current facility, for a number of reasons, doesn't feel safe for anybody in regards to her mother, but that a facility that is far quieter, that doesn't have much for physical commotion, is probably going to be the better choice for her mother. And I made a couple of suggestions to go tour and think about even a different secure memory. And these are all these facilities I'm talking about. They are not a skilled nursing facility. They are all with less than that skilled nursing facility qualification, that she will do better in a quieter location with maybe a little bit more consistent staff. There are a few locations, at least in my neighborhood, that have managed to hang on to their staff and are doing fairly well with their residents staying stable.
And Isabella?
Yeah, so my suggestion was around trying to mix her medication and her coffee. It sounds like she enjoys drinking coffee, although I don't necessarily think that's the right thing to do, but if the family is willing to try, could be an option, as long as, it doesn't change much the flavor of the coffee and the medication stays stable.
Yeah, that's a great suggestion. I hadn't thought of that. And I truly don't know, other than my own experience with a few cough syrups, what these liquids actually taste like, whether it's something that she would want to spit out, whether it tastes like that kind of sickly sweet syrup. I don't know. Does anybody know what these medications in general, how palatable they actually are?
Well, and you wonder about her sense of taste, right, in terms of both the neurological process and whether that was a side effect of having COVID. But I also appreciated the comment about perhaps switching her to decaf to take some of the edge off.
Yeah, I hadn't thought of that either. No, that's a great thing. I see that the coffee is you know, pushed at this facility as something to do during the mid-morning and the mid-afternoon. There is always coffee available for the residents, and asked if they want it. And I don't know how good really that is for them in the long run, but it feels familiar, I think, to them.
Allison, you also had a great comment in there. I saw you had your hand up for a while. We were working through our community here. Do you want to unmute and share that?
Sure. Yeah, I've seen successful administration of medication when the med tech has on her phone or her tablet a video of the family member or a doctor, whoever it is that the patient trusts, just a really short video saying, "Hey, mom, it's time to take your meds. Take your medication," when it's offered to you.
Okay. Okay. Yeah, that is a good idea. I know that, as I said, the patient still recognizes her spouse, still recognizes the daughter, and trusts them. Yeah.
Yeah. Other suggestions, recommendations? Thoughts about this particular case? Trey.
Hi, Deborah. Such a complicated cases. We hear crises like this a lot of times. I guess from what I'm hearing is that the patient is having pain and the gabapentin seemed to help. And I also am hearing that sertraline also seemed to help. So instead of adding more medications, because she's not taking her medication, she's been refusing anyway. So maybe go back and focus on the ones that she's already on and it's working, and to find out if there's any other possible way for her to take it, like the liquid. Is she able to take liquid, or she's still not able to take liquid because she can taste it?
It just got changed this week. I haven't heard back from staff because it takes a couple of days between my order to sending it to the pharmacy and then the pharmacy producing it, you know, and getting it in the med cart. I haven't heard that she's been spitting out all of the liquids, but I just don't know yet. It's only Friday. Everything except for the trazodone is available in either a disintegrating or a liquid form. And yeah, all great suggestions. I have increased the gabapentin, and the sertraline was a doubling of a dose from, I think, 2 months ago. But I think it's good to continue to focus on those as, yes, the most effective. Do you know, is there a palatable, are those liquids actually kind of a medicine taste still?
Unfortunately, I don't know, but I know that gabapentin is available in liquid, and and that can be switched to a liquid, and same thing with sertraline. And then another one is trazodone twice a day. And if she's not having sleeping issue, I'm not sure why she needs another dose during the day, because it is 50 milligrams a day. So maybe cut it down to once a day. And if she doesn't have a sleeping issue, maybe she might not need it. So that's that I would go back and just kind of focus on the medications that's working for her, and just change that and work in a way that she can be compliant with those medications first.
Yeah.
Before adding Buspar or Buspirone.
Good. And Janine?
Hey there. So I'm curious, you had mentioned consulting with palliative care, and do you need to make a referral for them? And I guess what's the goal? Because I'm not sure what that would add, because it seems like you're doing a great job with trying to manage things and figure out what to do. But
oh, I don't know about that.
What's the goal of consulting with them? Because as we know in primary care, we're mostly doing that, as our presenter said.
Yeah, I think originally the family was thinking that she was like irretrievable, that there was nothing more to be done. but they didn't imagine her dying soon, but they didn't know what else to do. And this was a discussion, the palliative care consult was a discussion that was started in the hospital. And I think the family was like, okay, maybe palliative isn't where we need to go. Let's continue to try and adjust her medications. And now we're to the point where we're a month later. Nothing is really changing. And so now they're back to that, let's try the palliative again. And I'm like, okay, I don't know exactly what is possible with that, but I can make the referral again and see. I am concerned though that when you get too many cooks in the kitchen, it can be a struggle, and the family gets a little bit overwhelmed with who's doing what. I agree, especially if there's no clear idea. Okay, maybe it's pain, but maybe it's just cognitive struggles, and she's had them for a whole life. We can't expect to resolve all of those with a couple of medications, in a couple of weeks. So the family though, as of this week, they just want her out of that facility, and they're willing pretty much to do anything to get her out of the facility.
Thank you.
Yeah.
Trang, did you have a follow-up comment or?
Yes, I looked up the gabapentin solution. It is strawberry flavor, so I think it might be okay. But the sertraline, it doesn't tell me the flavor, so I'm not too sure.
Okay.
If it's good or not.
That is some real-time research. Appreciate that. All right, and Franja.
I just have one quick thought about, where palliative might come in. I agree. So doing that PCO referral, it's not going to be managing the pain. I think if anything, it will be supporting the family, taking a little bit off of your plate to hear their stories, kind of hear where they are and try just to support them, because it's just difficult. Sometimes it's just sitting in the stress and the frustration alongside them that lets them be able to name all those things, so they can get back to, okay, this is just where we are right now. Yeah. So sometimes it's just that, and that's actually really valuable in them being able to continue to show up for their loved one. So yeah, just a quick thought. I know we're getting near the end. Yeah.
Wonderful point. Wonderful point. And Karen, I noticed you had your hand up and you took it down. Did you have something you wanted to?
I wanted to sort of acknowledge about what a great service that you did, Deborah, by sort of making more clear to the staff there about who this person was, what her habits were, those sort of things, because that's a great, the fact that she used to has always been somebody to walk around a lot. It's really important information for them to have. And maybe there's ways that more staff can sort of jump in to, take her for more walks to try to give her that exercise. And then also just that being the sort of like the person who's saying like, this is actually a whole person who had all of these things too, to really humanize them in that situation.
Okay. Yeah, to Mimi's point of, who she is, right?
Yeah. At this point, I don't feel like she is irretrievable. I think it takes some time to adjust, and I just don't know if that facility has any more time to give. Yeah. For many legitimate reasons. Yeah.
Yep, and lots of comments in the chat about similar experiences in even the best places struggling right now with staffing and training. And so we are indeed at time. Any last minute, 30-second other words of wisdom or suggestions for Deborah? In addition to the excellent care she is already providing for this person and family. All right. So we have some other resources that were mentioned in the chat. We'll be sure to send those out. And thank you for a wonderful discussion around a difficult case, and one that's not unfamiliar to all of us. Deborah, when you offered to do a case, we recently shared a very difficult scenario also, and I was thinking that might be the one that you were going to present. Deeply appreciative of the care you provide. So,
well, you can thank my boss Tanya Spoon with the Manette Clinic for giving me the time to do it.
Yeah,
that's hard to do in big facilities.
It is indeed, in time. Oh my gosh, how important. Speaking of time, I'm going to share with you next time on June 10th, we have a fantastic didactic by Jessica Caldwell. Dr. Caldwell is the director of the Women's Alzheimer Movement Prevention Center down in Las Vegas at the Cleveland Clinic. So that'll be Friday, June 10th. We would, Allison, I don't think we have a case for June 10th either, do we?
We do not yet have a case for June 10th.
Oh, we would love one. And of course, we'd also love your completion of the post-session survey as we continue to try to make this the best possible program. And thank you all for your time, your efforts, your dedication to doing this. It is difficult and not exactly glamorous work, but boy, it's important. So really appreciate it. See you next time.